Our next speaker is Ethan Marin. Dr. Marin is a nephrologist and an assistant professor of medicine at Yale School of Medicine. He's an active researcher in areas of renal physiology. Dr. Marin will share Yale's recent experience with monitoring renal allograft function in the age of COVID-19. Dr. Marin.
So, like most programs, we very carefully monitor our patients in the time period immediately after the transplant. We have over 20 clinic visits scheduled in the first year after transplant, including 2 a week in month one a week in month two, and 2 in the third month. With all these visits, we do a whole panel of lab studies, including traditional biomarkers of kidney function, like creatinine and urinary albumin. We also do for-cause biopsies at any time when we suspect trouble with the allograft. And further, at the 6-month mark, we do a protocol biopsy. Our practice has been to treat rejection when we find it on these protocol biopsies, according to the table shown here. So we, of course, treat antibody-mediated and severe T-cell mediated rejections aggressively, but we also treat borderline and BAMF1A cellular rejections with a steroid pulse and taper. And once the treatment is over, we increase the basal immunosuppression as well. So why do protocol biopsies? Well, the logic is as follows, that the traditional biomarkers that we follow for creatinine, proteinuria, are relatively insensitive and relatively nonspecific for rejection in other pathologies. And we think that the literature suggests, although we acknowledge some controversy, that significant fractions of newly transplanted patients will have subclinical rejection, meaning rejection not indicated by elevations in creatinine. Further, subclinical rejection untreated is associated with worse graft outcomes. And finally, that if we can treat rejection when we find it, based on these protocol biopsies, we can improve graft outcomes. So the gold standard for detecting these subclinical rejections has been the kidney biopsy. The biopsy can pick up, of course, a wide range of different types of rejection, and also other pathologies such as tubular atrophy and fibrosis, and infections due to bacterial and viral sources. So despite those advantages of the biopsy, there are many clear disadvantages. Anyone who's participated in a kidney biopsy program is familiar with the risks. Significant amongst them is bleeding. The kidney is a very vascular organ. Poking it with a needle is fraught, and bleeding can happen with an appreciable frequency. Shown below is actually some ultrasound and CT images of consequences of a biopsy in our practice, where the patient developed an AD chilla that led to a subcapsular hematoma, shown in this ultrasound image that ultimately required operative intervention. So the allograft can be damaged by a biopsy, as can surrounding structures, and the risks is heightened in many of our patients that have intraperitoneal grafts or need anticoagulation. Biopsies cause a lot of patient stress. They use up a lot of clinical resources, and there are well-known difficulties in interpretation, including sampling error and inter-observer variation. So, layered on top of those existing difficulties with kidney biopsies has been, for us, the COVID-19 pandemic. New Haven, Connecticut, the home to the Yale School of Medicine, has been particularly hard hit. We're just 70 miles from New York City. The small state of Connecticut has had over 3,000 deaths. Yale New Haven Hospital had over 400 COVID inpatients at one point. Our MICU service nearly tripled in size, and our living donor transplant program had to be suspended, and the deceased donor program severely curtailed. Our transplant clinic was nearly emptied out, with visits converted to telehealth. And in this environment, our protocol biopsy program became very difficult to continue. So this prompted us to accelerate a process that was already underway for us, and that is the examination of non-invasive methods of detecting subclinical rejection, so as to replace the protocol biopsies during this period of time. So we began a review of the commercially available tests that were out there, and found there's basically two technologies at present. The first is technology and testing based on the detection of donor-derived cell-free DNA. And the principle is that when the allograft is injured, cells die and release DNA, donor-derived DNA, which then circulates in the peripheral blood. This donor-derived cell-free DNA can be identified and quantified using next-generation sequencing techniques. And this technique has been studied in a number of publications. Most of the patients studied so far have been in the context of for-cause biopsies, not protocol biopsies. And the data show that the cell-free DNA is actually pretty good at picking up severe rejections, antibody-mediated rejections, and severe T-cell mediated rejections. However, it's pretty insensitive to borderline and BAMF1A rejection. The other technology that's out there, commercially available, of course, is the peripheral blood gene expression profiling test. And these tests are based on the concept that panels of genes and their expression profiles can be measured in peripheral blood and can be identified so as to reveal the presence of subclinical rejection. And these tests were specifically developed and studied to detect subclinical rejection. A number of different groups have identified them. The one that's been commercialized, of course, and is commercially available at present is the TruGraf test, which was based on a gene expression profile test developed primarily at Northwestern University. And clinically, these tests have been studied extensively in the context of patients who would otherwise get protocol biopsies, meaning patients with a stable creatinine below an absolute value of 2.3. The threshold for this test was chosen so as to accentuate negative predictive value, 90%. And the concept is a negative test allows a practitioner to forego a protocol biopsy with relatively high confidence of not missing a clinical rejection. So with this information in mind, we instituted the following plan in our own practice. We suspended protocol biopsies back in early March as the COVID pandemic was hitting us, and we planned to substitute our protocol biopsy with the peripheral blood gene expression profile, the TruGraf test. And positive tests would be followed up with a biopsy, and negative tests we would continue to monitor. We have continued to do clear for-cause biopsies when indicated, and we have incorporated cell-free DNA testing, but in the context of these for-cause biopsies in patients who are deemed risky to biopsy for different reasons. In particular, patients with new DSA, where we're trying to ascertain the clinical significance, we've used the cell-free test as well. As with any new test or any new technology, we've run into a couple of challenges in incorporating the new test. The first has been the need to add the test to the Yale New Haven Hospital electronic medical record, which is EPIC in our case, and prepare our hospital blood draw station to be able to appropriately perform the test. This has been accomplished, but took a little bit of effort. The second issue to be addressed has been insurance coverage. Medicare pays for the TruGraf test, but some of the private insurers in particular have required lengthy pre-authorization processes to pay for the test. And this has been challenging, in particular because we've had staffing shortages due to COVID-19, with several of our nurse coordinators being pulled away to do in-hospital duty on COVID floors. Lastly, we've had to embark on a process of educating the transplant group at large to make sure everyone's aware of the characteristics of the gene expression profiling test and has an understanding as to the appropriate time to order the test and how to interpret the results. So going forward, I think that this is a fast-moving field, and we've had to make a lot of changes in our practice due to COVID. I think many of those changes, such as an increased use of telehealth, are probably going to stay with us. And likewise, I think an increased use of non-invasive measures of allograft monitoring, such as TruGraf, are likely to remain part of our practice going forward, even after the COVID pandemic recedes. As I mentioned, the field is fast-moving. There's already studies underway to examine the performance of different non-invasive tests in a wide range of clinical settings. A number of new tests are under development, and publications suggest new technologies on the way, including tests that are based on combinations of different analytes, which will hopefully yield improved sensitivity and specificity. With that, I will conclude, and I thank you for the opportunity to discuss our practice at the Yale New Haven Hospital Transplant Program. Thank you.